centers performed 51 to 80 procedures per year, and high volume centers performed greater than or equal to 81 procedures a year. These volume categories were constructed such that we would have an equal division of transplants in each volume category in period 2, the middle period in our study. Our statistical analyses assessed temporal trends in volume by ordered logistic regression. We also assessed unadjusted survival rates by the ANOVA analysis and aggregate O/E ratios within periods we compared by chi-square analysis. We found in our study of more than 34,000 liver transplant recipients at 104 transplant centers that the total number of procedures had increased 25% from period 1 to period 3. That's an increase of more than 10,000 transplant procedures in period 1 to more than 12,000 in period 3. The percentage of those transplants done at high volume centers increased significantly from 28.2% to 36.7% over that time, while the percentage of those transplants done at low volume centers decreased from 40.7% to 29.9%. In fact, the odds ratio for an adult liver transplant being performed in a higher volume center in each consecutive time period was 1.24, with a 95% confidence interval between 1.2 and 1.9. Since we found that the percentage of transplants performed at higher volume centers was increasing, we wanted to examine whether or not this was due to the growth of existing high volume centers at the expense of low volume centers, a phenomenon known as regionalization. In this figure, we depict geographically all transplant centers in the United States stratified by volume. The black dots represent low volume centers, the gold dots medium volume centers, and the red dots high volume centers in period 1. When we compare this to a similar figure in period 3, we'll notice that many of the centers will change volume categories. Many low volume centers will move on to the medium or high volume categories. I'd invite you especially to pay attention to Chicago or the Dallas region to see these changes. When we then look at period 3, it's obvious that by the changing landscape that many of the centers have increased their volume categories. Further, when we compare just those centers who have increased or decreased volume categories, or centers that have started or stopped their transplant programs, we can see similar changes. The gold dots on this representation represent centers which have increased their volume and actually moved into a new volume category, or those centers which have started programs from period 1 to period 3, and the black dots represent those centers which have decreased or closed their program. Here we see that 26 centers actually either upgraded their volume status or started a new program, while only 9 centers downgraded or closed a program. Also, when we examine patient outcomes stratified by center volume, we find several things. First, we find that overall improvement in survival in the 1-year unadjusted survival overall from period 1 to period 3, so where survival moves from 86.7% overall to 88.3%, a significant improvement. This improvement is accounted for primarily by the low volume centers, which in period 1 have an unadjusted 1-year patient survival of 85.2%, while by period 3, that number has changed to 87.5%, which is a significant improvement, versus the medium and high volume centers, where overall 1-year unadjusted patient survival does not show a similar significant improvement. Furthermore, when we look within a time period, we can see a discrepancy in period 1 between low volume and high volume centers' aggregate O/E ratio. In period 1, the O/E ratio of 1.13 for the low volume centers is significantly different than that of 1.05 for the high volume centers. However, by period 3, the ratios in low volume centers 0.87 and for the high volume 0.94 are not significantly different. We recognize that our study has a few limitations, most notably the construction of our volume categories, which our categories are defined by absolute volume, which is constant throughout each time period. And since overall transplant volume has increased, we recognize that we should see increase in the high volume categories. Also, our use of aggregate O/E ratio is based on the assumption that the SRTR estimation of patient outcomes provides the best possible risk adjustment available. this model has been extensively validated. In summary, we found an overall increase in national transplant volume, a 25% increase from period 1 to period 3, and an increase in the proportion of procedures performed by high volume center that results in part from the growth of lower volume centers. We also found the volume outcome relationship is dynamic over time. In period 1, we saw that the aggregate ODE ratios were significantly higher for low volume centers, but by period 3, that discrepancy was no longer significant. Finally, we saw improvements in centers meeting criteria for review by the OPTN. Based on the SRTR data, there are 3 review criteria for center designed to find centers that are poor performers. And of the centers meeting these criteria for review in period 1, low volume centers accounted for 6 of 7 of these. However, by period 3, all but 1 of those had shown significant improvement. These findings suggest that the use of volume as a marker of center quality is not justified. Policy initiatives based on center volume are not supported given the dynamic nature of the volume outcomes relationship. Also, existing performance-based review based on risk-adjusted outcomes may improve overall patient outcomes, as we saw with the low-volume centers, which were the only category to show significant improvement in unadjusted patient survival from period 1 to period 3. We postulate that one reason for the decline in the prominence of the volume to outcome relationship for liver transplant is the presence of a thorough review process based on risk-adjusted multivariate outcomes analysis. The implementation of such a procedure-specific review process may obviate the need for volume-based referral for non-transplant procedures, as well as in liver transplant. We'd like to acknowledge our co-authors, as well as thank